Can you see my screen now?
Assalamu alaikum warahmatullahi wabarakatuh. My name is Rana Kamran Mahmood. I am the moderator today for today's session. Today we are going to discuss antipsychotic, which will be discussed by Dr. Shamma Irfan. She is working in the Guardian Pharmacy, Ron's Pharmacy Services long-term care pharmacy in the US. Dr. Shamma Irfan, can you please start the presentation? Thank you.
Thank you, Dr. Kamran. Okay, as Dr. Kamran introduced me, I'm going to give you guys a brief overview on antipsychotic. So in this presentation, we are going to discuss about schizophrenia, depression, bipolar, and all the way up to tobacco cessation. So first, I'm going to start with the schizophrenia. So I am assuming that you guys know about schizophrenia, and I will briefly discuss what is the condition, and I will go on case studies. So schizophrenia is a chronic, severe, and disabling thoughts disorder that occur in 1% of all societies, regardless of color, class, religion, or gender. So if and the gold standard to diagnose schizophrenia is DSM-5. Patient has to identify at least 2 of the following symptoms for at least 1 month. There is no chemical testing. You cannot. So if doctor is diagnosing someone with schizophrenia, it is mainly on symptoms that they present with. So there are 3 categories of symptoms. First one is positive, second is negative, and cognitive impairment. So positive means something is there that should not be present, like hallucination or delusion. Or negative means they have like absence of something that should supposed to be there, means that they do not have like they have dysfunctioning, or they cannot speak, or they have reduced ability to experience pleasure. And cognitive impairment mean the memory is not working. So if we talk about treatment options, we have 2 antipsychotic generation. First one is called typical antipsychotic. That's called first generation antipsychotic, and the second one is atypical. Those are the newer antipsychotic and have lesser side effects. I'm going to talk about that. So if we talk about first generation antipsychotic, we just need to know like what are those agents, like Haldol, fluphenazine, and then like all the way you can see on my screen. And if we are talking about first generation antipsychotic, we have to keep in mind which one is high potency, which one has moderate, and which one has low potency. Any antipsychotic which has high potency, it has more EPS and NMS, means neuroleptic malignant syndrome. Potency has more chances of having those side effects. Okay, I'm talking so these are the if I'm talking about extrapyramidal side effects, that's one of the side effects of atypical antipsychotic is Parkinson-like symptoms, like means that patients have rigidity, tremor, or like have hard time like having movement or muscle stiffness. We need to know about the treatment options. If patient has those type of symptoms, we can mainly treat with diphenhydramine, trihexylphenidate, and benzotropine. If patient is experienced, if we are going to have like, if we going to put patients on high potency antipsychotic and is experiencing acute dystonia, then the main treatment option will be anticholinergic, and we can see all those options. Like if in case of ataxia, that's like a condition of restlessness and inability to stay still or calm. In those cases, we mainly treat those patients with beta blockers such as propranolol and nadolol. And sometime in acute anxiety, we can also treat those patients with benzodiazepine. So those are the treatment options we need to keep in mind, that if patient is experience this, and that condition, then the main treatment options will be those. If I mentioned in my previous slide that patients may with high potency antipsychotic, they may experience EPS, extrapyramidal side effect, or neuroleptic malignant syndrome. So neuroleptic malignant syndrome is a condition in which patient may experience agitation, confusion, have high fever, tachycardia, or sweating. In this case, like if patient has experienced those symptoms, main of treatment options are we immediately has to discontinue the offending agent, give supportive therapy like normal saline, give hydration mainly. And if patient is experiencing like muscle stiffness in those cases and have high fever, dantrolene and bromocriptine are the main treatment goals. So I would say that this slide is very important. We need to know this very well. In this slide, like mainly I am presenting or discussing what are the main side effects of those antipsychotic. And if we see on our left-hand side, these are the second generation antipsychotic: clozapine, olanzapine, quetiapine, risperidone, and all these agents. If we are talking about side effects, then we are mainly categorized into three, like metabolic syndromes. Metabolic syndromes are mainly like weight gain, diabetes, and dyslipidemia. Then we also talk about sedation, EPS, and hematological effect, like which one can affect on WBC's count or A1C. So if we are talking about, we categorize, normally you need to know if we are talking about metabolic side effects, the highest risk factor is, like you guys can see here, highest. So if we are talking about metabolic side effects, um, clozapine, olanzapine, and quetiapine has the most, and the lowest one, those has the lowest risk factor. We can see here is aripiprazole, ziprasidone, lurasidone, and asanapine. Moderate risk factor, those agent who carries moderate risk factor is risperidone and paliperidone. So know these side effects very well. It will help you for any case studies or to answer any exam question. And for example, if we are talking about clozapine has the highest hematological risk factor. The quetiapine carries the lowest risk factor for EPS. And if you can see here that paliperidone has the highest risk factor for it can increase prolactin. And we also need to know that if we are combining those agents with the tricyclic antidepressant, it may cause arrhythmia. Some of them supposed to take with food like Geodon. Some of them doesn't matter, you take with or without food. So just keep in mind. So, I mean, duration therapy, therapy duration, like you can see it here that like some people like takes years to get stable on these antipsychotics. Some may have complete remission, and some 50% of the population may relapse. So it is very important uh, for patient to be on these antipsychotic on a regular basis. So now I'm going to just discuss about a case study. And as you can see here, this is our case number 1, a 25-year-old man, BMI 35, so it means patient is overweight, was recently given a diagnosis of schizophrenia. He often hears voices telling him he's stupid and worthless and that he should just jump off his apartment building. His parents become very concerned about his isolative behavior and brought him to the hospital. He was given Haldol in the psychiatry unit and now present with neck stiffness and an oculolaryngeal crisis. Until now, he has not taken medication because he felt that he could control his symptoms on his own with vitamins and energy drink, though he has difficulty remembering to take these. He has an additional history of marijuana and alcohol use disorders. So, and the question is, which is most appropriate for this patient's symptoms at this time? We have 4 options. First one is benzotropine, B, dantrolene, C, lorazepam, and propranolol. So if we are talking about this case, we need to focus on first one. It will help us. Sorry. So first of all, we can see that this patient is overweight. And then when he was at the hospital, he was given Haldol. Haldol, the moment we see Haldol, we need to think about, okay, Haldol is a first generation antipsychotic. And what are the side effects of those? So as we discussed in our previous slide, Haldol has the highest potency for neuroleptic malignant syndrome or extrapyramidal side effects. And we can see it here that this patient has neck stiffness. That's the type of extrapyramidal side effect. Number 2, you can see that this patient also has difficulty remembering to take his medication and has history of illicit drug use. So in this case, the best option for this patient is benzotropine, because you can, if, as I said, that we have to remember what are the side effects and what are we going to treat. Dantrolene option B is wrong because in most of the cases, dantrolene is for neuroleptic malignant syndrome, and this patient is experiencing extrapyramidal side effect. Option C is also not right because this patient is experiencing EPS symptoms, so benzodiazepine is not a good option for this patient. And option D again is not right because propranolol beta blocker is mainly to treat symptoms of ataxia, means when patient is restless, cannot sit still. Okay, then the second case is he's initiated on aripiprazole. Then again, we need to think aripiprazole is a second generation antipsychotic. Which is the best rationale for this selection? So option A has minimum risk of causing EPS. B is available in a long-acting injectable to increase adherence. Number C, aripiprazole would decrease this patient's negative symptoms. And number D is aripiprazole is only dosed once daily. So again, aripiprazole option A is not right because aripiprazole is an antipsychotic. It carries the potential for causing EPS symptoms. Option B is right because aripiprazole is available in a long-acting injectable form, like every 2 weeks or every 4 weeks. And if you see in this question, I highlighted the one that this patient has difficulty remembering to take his medication. So if we are going to start aripiprazole, we could transition this patient on a long-acting injectable. And option C is also not right because aripiprazole is not going to help for negative symptoms. And D is also not right because you can dose aripiprazole once or twice a day. Then we move on to the next question, that's which is the best example of an adverse effect of aripiprazole that could be a concern when initiated in this patient? So we have four options again: sedation, anticholinergic effect, ataxia, and D, corrected QTC prolongation. So in this case, the right answer is answer C, because if we are talking about the second generation antipsychotic, um, aripiprazole is most likely to cause ataxia, which is a form of EPS, and it involves a subjective feeling of restlessness. Second generation antipsychotic does not have it may cause sedation, but these agents are not as sedative as first generation antipsychotic. And aripiprazole, if we go back to our chart, it has less potential for causing QTC prolongation. So again, that chart that has all that side effect is very important to know, because based on that, we can pick the right answer. Then the next question is, 1 year later, he no longer responds to aripiprazole, and you decide to change his medication. He is only interested in oral medication. Given this patient's history, which agent is most appropriate at this time? So again, we have four options, and we are seeing first and second generation antipsychotic. If the right answer for this question is D, ziprasidone. And why ziprasidone is the right answer? Because option A, clozapine. Clozapine are reserved for those patients who do not respond to any other antipsychotic. And clozapine is reserved for refractory patient. When we talk about clozapine, we have to keep in mind that that I did not mention, that clozapine has RAMS program. It means that we need to monitor patient regularly. Once patient is starting clozapine, we need to check A1C, that's absolute neutrophil count, every week for 6 months, and then every 2 weeks for 6 months, and then every month for the next 1 year. And anytime if A1C is dropping less than 500, we're supposed to discontinue treatment. So again, for this question, ziprasidone option D is the most appropriate answer, because if we talk about clozapine, and the option B is also wrong, because that's the first generation antipsychotic, and we normally try to avoid those because of the side effects. Option C is not right because olanzapine has the most risk for metabolic syndrome. And we already noticed that this patient BMI is 35. So if a patient is overweight and obese, and if we are going to start olanzapine, then it may worsen the metabolic side effects. So now this is the end of our antipsychotic. I'm going to move to depression. So depression or major depressive disorder is one of the most common health condition in the world, and you can find like 60 or 70% people are depressed. People with depression suffer with persistent feeling of like hopelessness, worry, or poor concentration, lack of energy, inability to sleep, or sometime if the depression is getting worse, then they may have like suicidal ideas, suicidal thoughts. So again, the depression, there is a DSM-5 criteria. It is diagnosed when the patient has at least 5 of the following symptoms almost every day for 2 weeks. For depression, there are again, like we have to assess patient and there are therapeutic options available, and then we have to come up with a plan. If we are talking about depression, we need to know these two scales. First one is Hamilton Rating Scale for depression, and the PHQ 9. So I have seen those questions in the exam. So we need to know what are those depression scale to when we are diagnosing patients with depressions. When we are talking about depression diagnosis, we also have to rule out these conditions, that thyroid disorder, because many times you see that if patients have hypothyroidism, they may feel depressed. Or like if they have vitamin deficiency, mainly for D. We also have to check if patient is on any of these medications, like if they are interferons, like benzodiazepine, or they have been using alcohol or binge alcohol. Sometimes beta blocker may also cause depressive like symptoms, so we have to keep all, when we assess patient, we have to keep everything in mind. Then we are going to move to therapeutic options. There are psychotherapy, that's called cognitive behavior therapy options are available. Those are helpful for those patients who have mild to moderate symptoms. Then we have treatment options available, and in for severe patients who do not respond to pharmacological therapy, sometimes that they have to go to ECT, that's electroconvulsive therapy. Then our next slides are what are the current pharmacological treatment options available. The main, so different treatment options are available, like SSRIs, SNRIs, monoamine oxidase inhibitor, tricyclic antidepressant, or agents. Those have mixed serotonin medication and mixed serotonin activity, like bupropion. So if you are talking about, if we talk about practical setting, you mainly see like SSRIs, SNRIs, you may see bupropion and TCAs, but you hardly really see monoamine oxidase, patients on monoamine oxidase inhibitor to treat depression, because I will tell you next in my slide. So first of all, we are going to talk about the first one, tricyclic antidepressant. Again, you do not see in practice tricyclic antidepressant very often, because those have side effects, and mainly like in my practice area, like we normally avoid to give patient tricyclic antidepressant because of anticholinergic side effects, sedation, orthostatic hypotension, and sometimes it may also cause toxicity. It may cause like QTC prolongation. Then the next one is monoamine oxidase inhibitors. As I said, I hardly seen anyone on monoamine oxidase inhibitor because it has a lot of side effects. And also you have to avoid certain food that's high in thiamine because of the, again, drug interaction. For example, rarely if someone is going to start a monoamine oxidase inhibitor and is already on like SSRIs and SNRIs, then we have to wait 2 weeks and to make sure that drug is clearing from the body completely, and we can start. If we are going to start monoamine oxidase inhibitor, and for example, patient was already on sertraline, like SSRIs, it may cause serotonin syndrome that I'm going to talk. Um, it, here you can see that like normally you have to wait for 2 weeks, but like agents who those have like long half-life like fluoxetine, you have to wait 5 to 6 weeks. One of the advantage of monoamine oxidase inhibitors is it is also available in patch form. That's something you may see in the exam. Because you may get questioned that, okay, patient had hard time swallowing medication, what other options they can use. Salicyline, you may not see as an antidepressant, but patients who have like Parkinson type disease, you may see patients using those medication. And again, if you see that, you have to keep in mind drug-drug interaction and the washout period. So the first line agent to treat antidepressant is SSRI or SNRI. And we need to know what are those agents like fluoxetine, sertraline, paroxetine, citalopram, escitalopram, and fluoxamine. If we are talking again about antidepressant, SSRIs, we need to know side effects. So once we know our side effects, we can choose those agents based on patient's condition. For example, like if we are talking about fluoxetine, those are the most activating one. And if those are the activating one, for example, fluoxetine or sertraline, is not a good idea to give at night because a patient will be hyper and won't be able to sleep better. Then on the other side, if we talk about paroxetine is the most sedative one. So for example, if patient have depression symptoms and have hard time, difficulty sleeping, then you can prescribe paroxetine, and the good time to administer those medication is at night, because that will help to put them for sleep, and then they can also it can also help for depressive symptoms. And then again, there are other agents you need to know that if patient other side effects for SSRIs are like GI upset, insomnia, restlessness, headache, and sexual dysfunction is the main one that patients may experience. So in that case, if other agents are not working and patients is bother, then we can add bupropion for the treatment of sexual dysfunction. Also, like fluoxetine has the longest half-life, and when someone is starting antidepressant, it may takes about 4 weeks to see full effects. And again, if we are going to decide that either we need to discontinue any antidepressant or to change one antidepressant to another, in that case, we have to do gradual dose reduction. Otherwise, patient is going to experience withdrawal effect or side effects. We also have to keep in mind for citalopram that it may cause QTC prolongation. Again, my area of practice is geriatrics, and we just we are just making sure that if patient would not go up to 40 or over 40. I have hardly seen patients like those have like over 40 milligram a day dose. We also have to keep in mind that it may cause hyponatremia, that you may see in the exam, and bone fracture. It may increase the risk for bone fracture. If you, as I mentioned in the monoamine oxidase slide, it requires a 2 weeks washout period because of the serotonin syndrome. Again, serotonin syndrome is a condition that has, like, patients have neuromuscular hypersensitivity, like tremor, rigidity, and then agitated and have high fever. Again, in this case, the treatment option is discontinue the offending agent, supportive care. If patient have seizures, then we can always treat with like any anticonvulsant or clonazepam. And you can treat patients with aspirin for hyperthermia or Tylenol. Then the next one is SNRI. Again, we need to know which one is SNRI agent. We have venlafaxine, duloxetine, levomelnacipran, and those are the agent. So if we are talking about these SNRIs, for venlafaxine, I would say that we need to know for doses over 150, it may increase blood pressure. And venlafaxine is the most that has the withdrawal effect. So anytime if you want to change, if you want to discontinue or change it to other antidepressant, do the gradual dose reduction. The next agent that's important is duloxetine. Duloxetine is antidepressant, SNRI, and one of the other advantage of using duloxetine is it is approved for diabetic neuropathy. So, for example, if you have a patient that has depressive symptoms, and on top of that patient has diabetes or diabetic neuropathy, not diabetes but diabetic neuropathy, you can treat those patients with duloxetine. But you have to keep in mind, for all these antidepressant, you also have to keep in mind that those have drug-drug interaction, and those are CYP inhibitors. Liver toxicity is not that important, but also keep in mind. Levomelnacipran, I have not seen that agent prescribed for antidepressant. Those are mainly, but that's under antidepressant. Keep in mind that those are FDA approved to treat fibromyalgia. And you may also see that question in the exam. So the other mixed antidepressant that are available on the market is bupropion. So bupropion, as I said in my previous slide, that you can prescribe or augment for those patients who have sexual side effects. One of the other use for bupropion is smoking cessation. And it is, if, for example, if patient wants to quit smoking, the formulation is different and then brand name is different. That's called Zyban. So instead of seeing brand name Wellbutrin, that's the brand name of bupropion, you will see Zyban. And if you see Zyban, that's indicated for smoking cessation. If we are talking about bupropion, we have to keep in mind that it may decrease appetite and increase risk of seizure. So if patient has history of having seizures, and do not give more than 450 milligram per day. Then the next agent is trazodone. Trazodone is depressant, and plus it is helpful to treat insomnia. So if you see any elderly patient or like any patient who have depressive symptoms, and they also have insomnia problem, you can prescribe you can prescribe trazodone. Or if patient is already on SSRI or SNRI, and that's not working very well, and you want to add something, and patients have insomnia episode, you can always prescribe or treat those patients with trazodone. So the next one is mirtazapine. Again, mirtazapine, you have to know that one of the side effects of mirtazapine is increased appetite. So if you have a patient who lost their appetite due to depression, and they are already on SSRIs and all those first line agents, and you want to add something, so then add mirtazapine. Or if patient is losing weight, then add mirtazapine. So if you want to treat insomnia, keep in mind trazodone, low doses. So trazodone in high doses used to treat insomnia, and low doses is for depression. Mirtazapine for depression and who have like a weight problem or decreased appetite. So as I said, that it takes about 4 weeks to see full effect. You have to just keep screening patients for any side effect. And one of the major side effects are you also have to screen if patient have suicidal thinking or behavior. That's the black box warning. Then, as I said, that their combination therapies are available: SSRIs, SNRI, trazodone, bupropion, and you can choose your patient based on their symptoms. So which one is the best agent to augment? And then we also have to know that there are other antipsychotic approved for antidepressant like aripiprazole or olanzapine. Those are the one approved for the treatment-resistant depression. And then we are going to move to our case study. So the next question is: a 45-year-old woman has a medical history significant for sleep apnea, hypertension. So just keep in mind sleep apnea, hypertension, type 2 diabetes, chronic pain, bulimia. She is in the clinic today for an assessment of her depressive symptoms and the medication evaluation. She endorses sad mood, poor appetite. Poor appetite, lost 6.8 kilograms. That's a lot. Poor concentration and feeling of hopelessness and worthlessness for the past 3 weeks. She has also stopped going to her book club because she is not motivated to get out of the house, and she has frequent nocturnal awakening. She denies suicidal or homicidal ideation. He denies any use of alcohol, tobacco, or illicit drugs. She currently takes hydrochlorothiazide, metformin, hydrocodone, acetaminophen, that's the pain medication, and aspirin. Her current BMI is 20, that's normal, and her blood pressure today is 152/94. That's kind of high, but is not bad. She reports adherence to her current medication. And now based on her condition, we need to select which one is the best SSRI for this patient. So the option A is like citalopram, fluoxamine, paroxetine, and sertraline. So in this case, if you see here that she has frequent nocturnal awakening, in this case, paroxetine is the most appropriate medication in this case, because if you give sertraline, that's the most activating one. If she's going to get that, then it means that she would have difficulty sleeping. And then fluoxamine, that this medication has the most drug interaction. And citalopram would not be appropriate because in this patient because of the side effects. So the key point here is she has frequent nocturnal awakening. And then which antidepressant would be most appropriate for her depressive symptoms? So options are bupropion, fluoxetine, mirtazapine, and venlafaxine. So again, we have to keep this patient in mind that which one would be the best option. So if we are talking about bupropion, so I would say bupropion is not the right medication for this patient because, I mean, in this case, first of all, this is not the first line agent. Number two, she did not mention anything that she has having sexual dysfunction. B-fluoxetine is the most activating one. And if you see here, it is mentioned in the case that she endorses sad mood, poor appetite, and lost 6.8 weight. So the best answer in this case, based on the patient's presentation, is mirtazapine, because one of the side effects for mirtazapine is increased appetite or weight gain. So that would be helpful for this patient. And also we have to, I discussed in my previous slide that bupropion may decrease appetite. So in this case, that would not be the ideal situation. Then the next question is, it has been 4 weeks since her initial visit with you, and she has been treated with citalopram 20 milligram per day. So it has been 4 weeks, treated with citalopram 20 milligram in the morning. She's still present with sad mood, but her insomnia, concentration, and appetite have improved. She still has feeling of hopelessness and worthlessness, lack of motivation, and anhedonia. She has no adverse effect at this point, which is the best recommendation to optimize her therapy. So again, we have 4 options. Continue at current dose of 20 milligram per day. So, patient may see, as I said, full effect of antidepressant in 4 weeks. So she has been using citalopram for 4 weeks and still she has symptoms. So it means that we need to do something. Option B is increase the current dose to 40 milligram, add aripiprazole, or change to different SSRI. So in this case, B is the best option because she is responding. Like 4 weeks, she is responding with 20 milligram per day. Her symptoms are improving, but maybe she needs a little bit more. And for this patient, she is not old. So we can go up to 40 milligram per day. Option C is not the best option for this patient because aripiprazole is for those patients who have like refractory type of symptoms, but she's responding. Again, we can change to another different SSRIs if she has no improvement at all. Next question is 6 months later, she reports that although her depression symptoms have resolved, she has trouble during intercourse. So she has sexual dysfunction type of thing, which is quite disturbing to her. You determine that she has an orgasmia caused by citalopram treatment. That's a big one. So with all SSRIs, that the major side effects, which is the most appropriate recommendation at this time. So for this, again, we have 4 options: discontinue citalopram, add bupropion to citalopram, change to different SSRIs, or change to vortioxetine. So in this case, I would say change to vortioxetine, the option B, because this patient still needs an antidepressant. And discontinuing, we cannot discontinue citalopram because the symptoms are not resolved yet. And so option D, if we are going to, okay, in this case, option C is not right because um, change to different SSRI means she's going to, all SSRIs have those side effects. We cannot discontinue citalopram. So the best option is to change it to option D, because that, based on studies, is associated with the lower incidence of sexual dysfunction than any SSRIs. So in this case, the best option, we can also add bupropion to citalopram, but we have D option, and based on the studies, that agent is associated with less severe or having no side effects of sexual dysfunction. Okay, so our next topic is bipolar disorder. Bipolar disorder is a mood disorder in which mood can fluctuate from extremely sad or hopelessness state to an abnormally excited mood called mania. And you can see those patients. If patient is having mania attack, is in manic phase, they cannot even sleep for 2 days, or they cannot sleep at all. If you have experience seeing those patients. Okay, these are the pharmacological options for bipolar disorder. We have lithium, we have anticonvulsant, we have mood stabilizer. Sometimes we treat those patients depending on condition with benzodiazepine. But mainly for any bipolar disorder, we treat patients with lithium, any anticonvulsants like Dapaco, carbamazepine, or Lamictal, that's lamotrigine. And second generation antipsychotics are also proof to treat patients for mood, for maintenance, except brexpiprazole, clozapine, and allopurinol. If the main one is lithium, and you need to know for lithium that what is the half-life and what is the maintenance dose. And whenever patient is on lithium, it has to have like a therapeutic window. If patient is going below, it means subtherapeutic, lithium is not going to work. And if patient is over the limit, it means that patient is going to experience lithium toxicity. So mainly if patient is on lithium, we want to see patients somewhere between 0.6 to 1.2 most of the time. Sometimes depending on condition, you may go up to 1.5, but definitely not over 1.5 because of the lithium toxicity. And whenever patient is going to start lithium, we need to do pre-lithium workup. That's CBC, electrolytes. All electrolytes are balanced, otherwise it may cause lithium toxicity, and mainly thyroid function test. Lithium also has drug-drug interaction, and we need to know for lithium, like any ACE inhibitors, NSAIDs, or thiazide that may cause lithium toxicity. So if we are talking about lithium, we need to know lithium therapeutic level, what level can cause lithium toxicity, drug-drug interaction, and what labs needs to be done prior to lithium therapy. So again, I'm going to quickly move to case number 9. That will help you to understand better. A 26-year-old man with a history of type 1 bipolar disorder. And by the way, if any of you have any questions, I cannot see your chat screen. So Dr. Rana or one of you have to let me know if you have any questions or you do not understand anything. So case number 9, okay. So case number 9 is a 26-year-old man with a history of type 1 bipolar present to the inpatient unit. His wife found that he has withdrawing their life savings from the bank. He states that he is the perfect candidate for the presidency. So all that stuff, it looks a little bit weird, that withdrawing their savings from the bank, candidate for the presidency, hyperverbal, has not slept for past 48 hours. As I said, that those patients, if they are in manic state, they cannot sleep. He is placed on a 42 hours hold for control of his manic symptoms. He has a history of non-adherence to medication and currently takes none. Last hospitalization was 2 months ago when he had significant depressive symptoms and suicidal ideation. So that's the depressive phase of the bipolar disorder. He has 3 or 4 hospitalization per year, and his history of medical trial medication trial includes olanzapine and lamictal. He has also received a diagnosis of hepatitis C with an AST of 175 and ALT of 186. So in this case, those are the highlighted points that we need to pay attention. So question number 9, which mood stabilizer is most appropriate for this patient at this time? So I would say that the best answer, again, this patient has a bipolar disorder, and options are carbamazepine, Depakote, lamictal, and lithium. So if we are talking about which one is the best option, option B is the best option for this patient, because this lithium is the gold standard to treat any patient with bipolar disorder. If you are talking about carbamazepine, yes, you can use for maintenance therapy, but it's not a first-line agent. Again, we also have to keep in mind which one is the first-line agent, second and third one, and side effects. So we have to keep in our mind full picture. Option B, Depakote. Depakote, this patient has a liver disease that he has. This patient has hepatitis, and Depakote is not a good idea because it is cleared. It is cleared by liver, and if patient is and has compromised liver, is not a good idea to start a Depakote. And again, lamictal you can, but that's the third line agent. So the best option in this case is option D, lithium. That's the first line agent. Okay. Yes, so the next question is, which treatment emergent adverse effect would be the most concerned and would require immediate evaluation if he were prescribed lithium? So again, lithium side effects, we have to keep in mind hypothyroidism, number B, coarse tremor, C, severe acne, and D, weight gain. So as I mentioned in my previous slide, that symptoms include lethargy, coarse tremor, confusion, seizures, symptoms, and coma. So of course, the right answer is B. Okay. Okay, so the next question is, I'm sorry. 3 months later, he has been stable on lithium. So at some point, like patient had side effects, but like the dose were adjusted, and now patient is stable on lithium 900 milligram per day. However, during a clinic visit, he is confused and slurring his words. His current lithium serum concentration is 1.9. So concentration is 1.9. And remember what I said, we absolutely do not want to see lithium concentration over 1.5. So definitely serum concentration of lithium is high. He has been taking lisinopril and atorvastatin again for his hypertension and dyslipidemia for 2 months. He takes zolpidem for sleep. He began running a week ago. Running a week ago, he has been replacing fluid using an oral dehydrating solution Gatorade and taking ibuprofen around the clock for pain. So he began running a week ago. We have to pay attention on this. He began running a week ago. He has been replacing fluids using an oral rehydration solution Gatorade and taking ibuprofen around the clock for his pain. His other medication include lisinopril, atorvastatin, zolpidem, which most likely contribute to this patient's current clinical situation. So if you, as I said, that we have to pay attention on patient was stable on 900 milligram, and then all of a sudden serum concentration went up to 1.9, because so in this case, what happened in the middle of the time and patient all of a sudden experiencing side effects. So so B is the right answer, because patient was stable. Patient has been taking lisinopril. So ACE is not a problem. So whatever the problem was, if lisinopril has some drug interaction with lithium, dose was adjusted and patient was stable. But all of a sudden, this patient started ibuprofen. So NSAID has a big drug interaction. NSAID has a big drug interaction with the lithium. Gatorade electrolyte may cause some problem, but not as big as ibuprofen. Okay. Okay, so the next question is a 36-year-old woman. Okay. A 36-year-old woman with type 1 bipolar disorder present to your clinic tearful with a 2-week history of depressed mood, anhedonia, insomnia, feelings of worthlessness, and loss of appetite. She has passive thoughts of suicide. That's not good, but no concentrate plan. So she just started to think about suicide, but no, she hasn't planned how she's going to do that. She currently takes lithium with with a trough serum concentration of 1.1. So that's in the range. Which medication would be best to treat her current episode? So if we talk about this, so answer number C, C is the best answer for this patient. So this is the depressive phase of bipolar disorder. So in the last case, we saw manic episode, and this is the depressive, whoever have bipolar disorder. So this is an example of the depressive phase. In this case, C is the best answer, quetiapine. Quetiapine is the best answer. I'm sorry, I'm trying to see. Okay, can you hear me? Okay. Okay, so Lamictal is not the best option, because whenever we talk about Lamictal, lamotrigine, we have to keep in mind whenever we are starting, we have to titrate it up slowly. If, for example, if if a doctor is deciding that, okay, they have to start someone on Lamictal. So in this case, what you have to do, start slowly and go slowly. because because in other words, if patient is going to start taking, for example, 50 milligram twice a day, they may experience side effects that the rash, and those rashes are very bad. It can burn the skin. Venlafaxine is not the best option in this case. um, may increase the risk of changing her. So venlafaxine, she is in depressive mode, and that is the most activating, or like patient may go from depressive to manic phase. So also that's not the good choice. Okay, and then we will move on to our next case or topic. So the next topic is anxiety. So this one is, I mean, I would say that anxiety patient may experience, like we all get anxious anytime at some point in our life. But if anxiety, if someone is anxious all the time, that may affect in their life, then at that point, those patients have to go for treatment. So for any generalized anxiety disorder, these are the agents like SSRIs, SNRIs, bupropion. We have all those. We need to know all these agents, which one is good to treat. Also, for like bupropion, pregabalin, and it all depends like patient's presentation, what other conditions those patients have along with the anxiety. Then the next one is panic disorder. We can also have agents to treat for obsessive compulsive disorders. We need to know all of these agents. I'm going to quickly move to our case study. The next one is a recent Iraq War veterans has been treated successfully with paroxetine for his major depressions for the past 3 weeks. He presents to the clinic experiencing nightmares, feeling on edge all the time, and having flashbacks of his time in the war. He is evaluated and giving a diagnosis of PTSD. He has no history of substance dependence and no significant medical history. Which recommendation is most appropriate for this patient at this time? Again, so we have 4 options. Continue paroxetine because it treats both PTSD and major depression. Discontinue paroxetine and initiate sertraline, which treat both PTSD and major depressive disorder. Continue paroxetine and add lorazepam, and discontinue paroxetine and initiate buspirone for the anxiety symptoms. So in this case, the best answer is A. Continue paroxetine because it treats both PTSD and major depressive disorder. Sertraline can also, like option B, sertraline can also treat PTSD, but there is no reason to discontinue paroxetine. And adding like benzodiazepine like lorazepam and buspar is not indicated at this time. So I know that these answers are, sometimes it is hard to make sense, but if you read the case once or twice, it may help you to answer these questions. And again, like in exam, you guys will see that whatever questions or options you are going to get, those are like very close. And sometimes you debate that, oh, do I have to pick A or B, and then you just keep, sometimes, I mean, you keep changing your answers. Next question is, a 48-year-old man has newly diagnosed GAD. He cannot sleep at night. He reports frequent headaches. which he treats with ibuprofen. His family history is positive for depression and anxiety. Which medication would be the best for long-term resolution of his symptoms? So now we are talking about long-term resolution. Okay, we have to read this long-term resolution of his symptoms, and our options are Xanax, alprazolam, Buspar, paroxetine, and pregabalin. So the um, best answer is C, good, because both SSRIs and SNRIs are considered first-line agent for generalized anxiety disorder and associated with symptoms. And again, as it mentioned, that they want to resolve this patient's condition on a long-term basis. So alprazolam is not the best option. Option D, pregabalin, is not the first choice or first-line agent to treat generalized anxiety disorder. And Buspar, again, same. Buspar is not the first line agent. So if we are talking about long-term resolution and we have options available, like SSRIs and SSRIs, we always go with that. And there is nothing mentioned here that will help to navigate to go for the answer B and C for the second line agent. Next question is a 27-year-old woman with panic disorder. Now we are talking about panic disorder, is having difficulty functioning at work. She had her first panic attack while getting a cup of coffee. She felt she was having a heart attack and was seen at the local ED, where physical causes her ruled out. She has several subsequent episodes. She cannot predict when or where they will happen. Her absence from the work is high, and she's concerned about her job. Her medical history is otherwise unremarkable. Which medication would most likely allow her to return to work? So now here they are asking about which medication would most quickly allow her to return to work. So now we are talking about the short-term resolution. Earlier we were talking about long-term, and now we are talking about quickly. So we need to pay attention on quickly. So options are Xanax, alprazolam, Buspar, paroxetine, and venlafaxine. So in this situation, option A is the best option, because as we can see here that paroxetine first-line agent is available, but again, we have to do something that can quickly resolve her situation and she can go to work. Because Buspar and paroxetine, it will take some time. So SSRIs, it takes about 4 weeks. Buspirone is also taking time. So those are the agents we can go later to treat her panic disorder in a long term. But for now, Xanax is the best option. Okay, and the next question is, a 21-year-old woman has newly diagnosed OCD. She is unable to hold a job because she's so consumed by her obsessive and compulsive disorder. She's convinced that her obsession are reality. So that's the saddest part. Which is most appropriate to initiate? Again, options are bupropion, fluoxetine, imipramine, and mirtazapine, and the best option is fluoxetine, because for any OCD activity, it needs serotonergic activity. And the fluoxetine is the only agent that has that. Okay, and then, okay, now we are going to quickly move to the next topic, that's insomnia. So insomnia, again, is a condition where patient would not be able to sleep properly. So again, there are treatment options available, but before we go for any treatment options, we need to rule out, like if patient have any underlying condition, like for example, if patient have pain, of course, if anyone has pain, they won't be able to sleep at night. Or like if patient is taking coffee at night time, before bedtime, of course they won't be able to sleep. So those are the conditions that we need to rule out before we declare that, okay, this patient has insomnia. Or like if any medical condition, as I said, that like hypothyroidism, it may cause insomnia. um, so and like or as discussed, like bipolar, patient is not able to sleep for 48 hours or 24 hours. So those are the conditions we need to know in order to diagnose insomnia. And insomnia is diagnosed when the patient has symptoms at least 3 times per week, and at least 3 times per week for 3 weeks. So again, and before we start any medication, we also have to work on sleep hygiene. Mean like where patient is sleeping. Does patient have comfortable bed, or like any place where patient is sleeping, or like if patient is sleeping in dark or light. Maybe patient is used to sleep in dark, and like a room is full of light, and also like a room is cold or warm. It all depends on what patient is comfortable for. um and then different agents are available. Like we have two treatments options available: benzodiazepine and non-benzodiazepine. And like others, like for example, under others you will see trazodone. So those are the class of medication that you can treat, both like you can use for depression symptoms or like for sleeping. There are other OTC medications are available, like doxylamine and diphenhydramine. um, I'm talking first quickly or for those agents, because then I will talk about benzodiazepine and non-benzodiazepine. You can get like Benadryl, diphenhydramine, that may help to sleep. But again, like in my practice, we normally avoid giving to elderly patients because of the anticholinergic side effects. And also, if patient has dementia, like in or Alzheimer's disease, it may worsen dementia symptoms. So benzodiazepine, we normally avoid benzodiazepine, and we need to know agent's name, like diazepam, lorazepam, and all those agents. Um, uh, we need to know side effects, tolerance, residual daytime sleepiness, avoiding elderly because of the risk of fall. And then we mostly like to see non-benzodiazepine if we have to prescribe those medication. Normally in practice, you will zolpidem, you will see Sonata and Balsomra. You may also see Remeltron. And when we are talking about non-benzodiazepine, keep in mind that which agent helps you to sleep faster, means, or which one is good for sleep maintenance, and which agent for is good for both. It means that it will help to sleep faster, means onset of sleep. Like if patient is on bed, have those medication, they may sleep like in next 5 to 10 minutes, and they can sleep like at least. And those patients, some patients are like they have hard time staying asleep. They can sleep like faster, but they can fall asleep fast, but they cannot sleep for a long time. Like they cannot sleep for like 6 7 hours or like 5 hours. They may wake up like in next 2 hours. So also, depending on the patient's presentation, we have to keep in mind which agent is good and which agent can help for both sleep onset and sleep maintenance. And always non-benzodiazepine are preferred over benzodiazepines because of the side effects. And in case, like if you really have to choose benzodiazepine, always keep in mind LOT, LOT, Lot is mainly for elderly patients. A lot mean lorazepam, oxazepam, and temazepam. And if we can see in this chart, you will see that zolpidem and azopicolone, that's Lunesta, is in both category. Means it will help to sleep faster and it will help to maintain. Okay, so now we have case a 38-year-old kindergarten teacher present to the clinic today with noticeable dark circles under the eye. It means that the teacher is not sleeping well. She has difficulty with sleep, mainly with staying asleep. So as I said that you have to keep in mind which agents are good for sleep onset fast and then for maintenance. It takes about 20 minutes to fall asleep. So it's not that bad. But after 2 hours, she wakes up and cannot fall asleep again for several hours. This pattern has taken a toll on her job and she feels tired all the time. Of course, if you are not sleeping at night, she once took diphenhydramine for sleep, but had to miss work because of extreme drowsiness in the morning. So Benadryl has side effects of like daytime, like you may feel like drowsy, groggy, and you feel weird if you take Benadryl. She wonders whether she can take any other medication. Her other medical problems include hyperthyroidism. As I said, that whenever we are talking about sleep or in sleep problem, we have to rule out if patient have any medical condition. Her other medical problem include hypothyroidism, levothyroxine 125 at bedtime. At bedtime, I underlined that one, hypertension, hydrochlorothiazide 25 milligram in the morning, chronic back pain, ibuprofen 800 milligram 3 times a day, and MDD, mood disorder, citalopram 20 milligram in the morning. Which agent is most likely contributing to her insomnia? Okay, so the best answer in this case is levothyroxine. Um, Levothyroxine is the best answer because one of the side effects of levothyroxine is like insomnia type symptoms. So and she takes this at bedtime. So normally levothyroxine, the typical pattern you will see for levothyroxine, first thing in the morning on empty stomach, 30 minutes before breakfast. You can take also at bedtime, like on empty stomach, like after dinner, like 3-4 hours later, but the side effect is like it may cause insomnia. And citalopram may cause insomnia type symptoms because that's then activating SSRIs, but she's taking in the morning, so that's not a problem. And hydrochlorothiazide and ibuprofen, that those medication are not known to cause any side effects like a sleep difficulty. So question number 18 and 19, which medication used for insomnia is most appropriate to recommend for this patient? Trazodone, trazodone, no, she's already on citalopram and she doesn't have, like, we did not discuss anything about like depression, that she has worsening symptoms. Temazepam is a benzodiazepine. So as I said that if you have options for non-benzodiazepine and benzodiazepine, then we would go for non-benzos. And now the question is, you have to choose between A and D. And again, so we need to keep in mind that what symptoms she has. So the patient does not want a drug with significant daytime sedation, but she needs a drug that will help her stay asleep throughout the night. And option A is the best answer because option A, Lunesta, is in the category which will help you to stay asleep longer. Option D does not cause daytime sedation, but a short half-life and would not help her to stay asleep. Then next question is, which adverse effect of zolpidem would carry the greatest potential for harm in her? Option A, orthostasis, disorientation, abnormal behaviors while sleep seizures with high doses of the drug. So with zolpidem, when we are going to um, discuss the side effects of benzodiazepine, abnormal behaviors while asleep is one of the major one, and we need to know that. That's the typical. Okay, then I'm going to move quickly to alcohol abuse. I think this is the last one I'm going to discuss. Alcohol abuse is like alcohol is a CNS depressant and most commonly abused substance. Alcohol is absorbed in the duodenum and metabolized in liver. So we need to keep in mind, that's why all those alcoholic people, they have liver disease like cirrhosis. And for any liver, if liver is compromised, two main biomarker is ALT and AST. So in this case, we need to pay attention that which agent is good if patient have liver disease, and which one is the one if we can use if liver is not compromised. We also have to keep in mind acute therapy, nutritional support, thiamine is the main one, and chronic therapy, again, if patient has liver disease or liver is okay, and IV hydration. And also we need to know if someone has withdrawal symptoms, like what is happening in next 6 to 12 hours. So if patient have no alcohol in 6 to 12 hours, what will be the symptoms? If patient is presenting with mild tremor, agitated, restless, tachycardia, nausea, and sweating, we would say that most likely this patient stopped drinking in last 6 to 12 hours. And like if patient has delirium, tremor, confusion, then in that case that the patient is like has no alcohol for last 3 to 5 days. So just this chart onset, and this is important to know. Okay, we will move to our question. Question number 20. A 50-year-old patient with a 25-year history of alcohol dependence was found unconscious after his last binge drinking. He was first admitted to the medical unit for alcohol withdrawal symptoms before being transferred to the substance dependence unit. Last drink was 6 hours ago. So as I said that, then his last drink was 6 hours ago. So we need to know that what will be the symptoms he's going to present. And fluid had been initiated. He has had 3 alcohol withdrawal seizures in the past and an episode of delirium treatment. He also has significant hepatitis. So here, and liver function test shows AST of 220. So he has hepatitis, liver enzymes are elevated. Additional laboratory test value include albumin, alkaline phosphate, and all that liver workup, and creatinine. Which symptoms are most likely to observe in the medical unit in this patient? So his last drink was 6 hours ago. So alcohol craving, delirium, increased heart rate, and seizure. So C is the best answer. As I said, like you need to know this chart. Like in 6 to 12 hours, like tachycardia is one of them. In 3 to 5, delirium is not right. If you know that chart, you can answer this question very easily. And then which agent is best for his alcohol withdrawal symptoms? Librium, option A, number B, clonazepam, diazepam, and lorazepam. So answer D is the best option in this case for the withdrawal, because Librium is mostly for, I would say, is for acute treatment. Clonazepam is not indicated for alcohol withdrawal. You may use diazepam, but diazepam is cleared by liver. So this is not the best option because this patient liver is already compromised. Okay, next question is which medication is best for his alcohol dependence? So now we are talking about which one we can prescribe for maintenance. So again, these are this liver, if this patient has liver disease or compromised liver, these are the agent. And if for normal regular patient, so as we can see here that A is the best answer. And then next question is a 34-year-old man wants to stop using oxycodone. He has been buying it off the street and is using 160 milligram daily. That's a high dose. He is not interested in methadone maintenance. He would like to enroll in an outpatient program. He's 24 hours for his last dose. He's having some anxiety and muscle aches. He still start his treatment in the clinic, which is the best formulation and dose to initiate in this patient. And we have 4 options again, and option D is the best option. In this case, for opioid detoxification, if we are talking about outpatient setting, combination of buprenorphine and naloxone is the best option. And so we can think for like C and D, which one is the better one. So I would say that mostly in practice, you will see option D, 4:1 milligram. Okay, then the next topic is opioid dependence. Like for any opioid dependence, we have, so opioids are good. I mean, it can treat severe pain, but if patient is taking like, again, everything, if you are not using it properly, it may have potential for abuse and side effects. So there are many agents available, like some are short acting and some are long acting. And if patient has potential for abuse and wants to be on maintenance therapy, then the best option is methadone. And methadone, like that methadone has methadone clinics. They monitor patients because you can also abuse methadone. Methadone in low dose, like 5 milligram once a day, or 2.5 or 5 milligram 3 times a day. Methadone can be used to treat pain, and mostly you will see patients who are very sick and nothing is working for them. In that case, doctor prescribe methadone. But if patient has opioid dependence, the dose for methadone is high, like 60 milligram per day. And those like methadone clinics, normal pharmacies cannot dispense these medication. Patient has to go to those clinic and get methadone there. And again, like patient has, so these are the options, like induction phase, minimum dose, and the stabilization, maintenance, and then eventually our goal is to discontinue those agents. Our next topic is tobacco cessation, tobacco dependence. So tobacco, again, like for this topic, you just need to know like 5 A's. 5 A's are very popular. Like that's willingness to quit should be accessed by the 5 A's. And you need to know what are those 5 A's, like ask about tobacco use, advise, assist, and then assist, and then arrange for follow-ups. So those are the 5. Whenever you talk about tobacco dependence, you will hear 5 A's. And again, there are different treatment options available, like gum, lozenges, patches, inhaler, nasal spray. In practice, you mainly see gum, lozenges, and patches. And if we talk about patches, if we talk about any like gum, lozenges, and patches, it depends how many cigarettes patients smoke per day, and depending on that we can prescribe. For example, if patient has like 10 cigarettes per day, So patches are available in 3 steps, 21, 14, and 7. And again, depending on number of cigarettes patient smoke, you can prescribe the strength that's appropriate for the patient's craving. You can also, patient can have patch, or they can take gum and lozenges to have those to avoid those cravings. And then there are other options, like, as I said, that bupropion is available in the market for the treatment of a smoking cessation, but the brand name is different. It is called Zyban. But again, we have to keep in mind all those side effects of bupropion that we discuss in antidepressant. And another treatment options that are available on the market is varicilline. So normally you start 1 week before the quit day, black box warning of neuropsychotic symptoms that you need to know. And then you can combine varicilline with the nicotine treatments. And then in the last, I would say that these are the side effects of all those, like antipsychotic, antidepressant, and all that agents, and you need to know about that. Also, like, one thing that I forgot to mention, that disulfram-like effect. So if those are the very bad effects, like, for example, if you take metronidazole, or like metronidazole is antibiotic, and you drink alcohol, you have that effect. So whenever patient is on metronidazole, like, you counsel those patients that, hey, do not drink alcohol, or do not take any product that contain alcohol. Otherwise, patient is going to experience disulfram-like reaction, and that's very bad, like nausea, vomiting. You feel weird if ever you guys experience, like, even like, it's not necessary that you drink alcohol. There are many mouthwash available on the market that has alcohol content. So normally it is recommended to avoid for 5 days uh, while patient is on metronidazole. And then the next important thing you guys need to know is inhibitors, like which one is the main inhibitor or substrate, because it will help you to answer those questions. And I think that's it. That's the end of my presentation. If you guys have any questions, let me know. I have answered for these questions. If any of you, I will email to Dr. Kamran, and either you can contact to me. My email address is, I'm going to write it in the chat box. You can send me an email and I will send those answers to you.
Thank you very much, Dr. Shamma, for your presentation today. It's really very well organized. No doubt, it's a comment from one of our participants, and I really appreciate your work, and especially the day that you have adjusted for us. And thanks for all of the participants for today. No doubt, we just changed the schedule because of some issues that we encountered from our lectures. Thank you very much, Dr. Shamma. And if there is any question, and if they will ask me, or if they will send you an email, obviously you will answer them directly. If they will ask me something, I will get back to you. Thank you very much, everyone.
Thank you. Thank you so much, Dr. Kamran. And I'm sorry about that. I was late a little bit.
No. Really, you help us a lot all the time. And because she's delivering the lecture from the US directly, and the time here there is the morning, and she has the night shift. And I know she has a lot of household stuff as well, and still she's one of our dedicated lecturers. She's presented on time, and really you take a special time for us and for our participants. Thank you very much again.
Thank you so much. Thank you. Have a good day. Allah Hafiz.
Have a good day. Allah Hafiz. Thank you, participants. See you, inshallah, on the coming Tuesday. So I hope We have our next lecture on the Tuesday, and see you all. Thank you very much again. Assalamu alaikum.